So basically, I am a physician practicing medicine and diabetes at Bhopal. I have my own hospital at Bhopal, and I am a chairman elect for RSS 3I MP chapter this year. This is my uh, uh, so my topic has already been strengthened by all previous speaker that all diabetic people should be screened for the MASLD, and that is what I am practicing in my clinic daily. But I'll give some data why should all diabetic people be screened for MASLD and how cost effective it is. So why do we screen for any illness for that matter? We do screening for early detection, prevention of complication, reduction of disease burden, public health monitoring, informed decision making, targeted intervention and research. So these are the general purposes of screening for any illnesses. And if we talk in context of the MASLD, the purpose of early detection is presence of NASH with or without fibrosis, so that we can achieve the ultimate target of preventing the cirrhosis and hepatocellular carcinoma, which are the most treated complications of MASLD. And MASLD the leading cause of these two diseases worldwide. But screening all people with MASLD is not possible, not cost effective, because of the sheer size of MASLD population. 39% of Indian people are suffering from MASLD. We cannot screen all those people for early fibrosis or NASH without fibrosis. So we need screening to be cost effective. We need better risk stratification to guide the targeted screening, and that target group is type 2 diabetes population. And it is a very slowly progressive disease. As sir has already shown, it takes 15 to 25 years for somebody to progress from simple steatosis to the advanced fibrosis. So we have ample time, we have many therapeutic intervention to halt the progression of MASLD or even to reverse some stages of MASLD before the advanced fibrosis has actually developed. We have GLP-1 analogs, we have lifestyle interventions. MASLD in early stages before advanced fibrosis is actually reversible. And single most important point is, if advanced fibrosis can be prevented, most of the liver related outcomes including hepatocellular carcinoma can be prevented. So these are certain data. This slide has been shown by previous speakers. 60 to 70% is the prevalence of MASLD in type 2 diabetes population. In our country falls into the category of around 60%. This might even be higher. If we talk in terms of different metabolic traits which are predisposing people to the MASLD, these are dyslipidemia, obesity, diabetes and hypertension, apart from the postmenopausal status, apart from hypertension. So with addition of each metabolic trait here, the risk of advanced fibrosis and HCC increases in the patients of MASLD. And diabetes confers the highest risk of progression to advanced fibrosis and HCC. And if the diabetes is associated with any other comorbidity like dyslipidemia, obesity or hypertension, the risk is even higher. And we know that almost all our type 2 diabetes patients are either having dyslipidemia or overweight or obese, or they are having hypertension. So this becomes one reason for screening of all our type 2 diabetes patient for MASLD. This slide was shown by Dr. Ashish sir. This slide is from, this is a data of study of biopsy proven MASLD patients. These people have undergone two paired biopsy more than 1 year apart from different studies, different registries, different therapeutic placebo arm of different therapeutic trials. And what they found, that therapeutic progression to fibrosis in MASLD population was significantly higher in type 2 diabetes MASLD population as compared to non-diabetic MASLD populations. Another what is the importance of doing screening is, you pick up those people who are at the risk of developing advanced fibrosis in the early stages. This is a study, again a retrospective analysis of all those patients who are developing HCC or cirrhosis when they were picked up in the course of their illness, either early steatosis or at the stages of advanced fibrosis. There was monotonically increase in the incidence of hepatocellular carcinoma with each stage of MASLD. Lowest incidence of HCC was in those people who were diagnosed at the stages of simple steatosis And highest was in those people who were diagnosed at these stages of cirrhosis. So you pick them early, you prevent the hepatocellular carcinoma also. Again, this is a very large data from 4 European countries, approximately 18 million people, those who were coded with the diagnosis of NAFLD and those who were not coded with the diagnosis of NAFLD were assessed for the risk and clinical predictors of cirrhosis and HCC in those people who were coded with the diagnosis of NAFLD. Again, the diabetes was an independent risk factor for progression to either HCC or cirrhosis, not only in those people of this population who were coded with the diagnosis of NAFLD, in control population also who were not coded with the diagnosis of NAFLD. So diabetes becomes a risk factor for development of cirrhosis in and HCC. That's why we should screen all our type 2 diabetes patients, and risk is bidirectional. This is a data from ADA which shows that incidence of coronary, which is the commonest cause of mortality before the liver outcomes develop, advanced fibrosis develops in the patients of NAFLD, is cardiovascular. And this cardiovascular risk in type 2 diabetes population is significantly higher in those people who have NAFLD or MASLD along with the type 2 diabetes. So this again becomes a reason of screening all those people of type 2 diabetes for MASLD. Again, therapeutic informed decision making and targeted intervention. How we treat our type 2 diabetes patient today? We target cardiovascular comorbidities, we target nephropathy, we use SGLT2 inhibitor, we use SGLP1 analog in majority, we try to use if they can afford, in majority of our type 2 diabetes patient. And these are the drugs now being advocated for the management of MASLD also. Bariatric surgery, weight loss intervention, GLP-1 analogs and SGLT2 inhibitor. These are the drugs. If we use on the basis of only MASLD in our type 2 diabetes patient, they are going to be benefited in terms of better cardiovascular outcome, better renal outcome, and overall better glycemic control also. And what do the guidelines say? ADA and combined guidelines from EASD, EASO and ESL. They also say that all type 2 diabetes patient, pre-diabetes patient and obesity plus one or more cardiovascular risk factor, they all should be screened for MASLD. And to summarize, diabetes is associated with highest prevalence of MASLD, highest risk of progression to advanced fibrosis and cirrhosis. There are many people of type 2 diabetes who are actually harboring undiagnosed cirrhosis, and this data is 15 to 18% in different studies. Diabetes with MASLD confers, it is a double-edged sword. CV illnesses are higher in diabetes plus MASLD as compared to the diabetes without MASLD. And diabetes management strategies like weight loss, lifestyle, GLP-1, SGLT2 inhibitor are preferred in those patients also who are having MASLD. And most importantly, FIB4 is the very simple, economical, available tool and accepted, validated worldwide to screen for early fibrosis in patients of MASLD. A case finding strategy depends on the FIB4, centers around the FIB4. So we have to do nothing. We have to just do the online formula, MedCal or any other app. We have to download and do the online calculation by getting just age of the patient, AST, ALT and platelet count. And one of the studies, even they advocated the lower cutoff for the diabetic population for further screening by fibroscan. General cutoff for the all population of MASLD for doing fibroscan is 1.3, but they suggested it should be 1 for the diabetic population to improve the sensitivity of screening for the advanced fibrosis. So that's all in favor of doing screening for MASLD in all diabetic.
At the outset, I thank Dr. Bansi and Amit for giving this opportunity. Today, I am speaking against the wind, speaking in liver interest group against the screening of the MSLD. But my task is already done by my previous speaker. He has already said that it is not possible to screen everyone and every diabetic patient for MSLD. The target should be like of a high risk screening. As we know, the MSLD is, as previous speaker has already discussed all these things, the pathophysiology and epidemiology. There is a 9 to 53% of the prevalence across the India, and in diabetic there is a 45 to 72%. close to the 50 million individuals. Is it possible to do screening in all these persons in a restrained, constrained in country or like India? Probably not, because we have at least 100 million people of diabetes in 2013, and in 2019 we have 77 million. Is it possible to screen every patient? And apart from that, 43.9 million patients are don't have, they are undiagnosed of diabetes. I think Indian government should make a rule to diagnose or to investigate every person above 18 years for diabetes. That will prevent all these other things and complication, and save the so many economic burden to the country. And apart from this, we have 136 million people with pre-diabetes. That is also, most of them are also undiagnosed. So our resources should be emphasized on to detection of the undiagnosed diabetic and pre-diabetic patient instead of the screening of the diabetic patient for liver disease. What are the challenges? We don't have a healthcare infrastructure, especially in the rural setting. There is a financial constraint. Universal screening will require the substantial investment and potentially diverting funds from the other critical health services. Most of our situation is like that in India. Most of the health projects have these problems. And MSLD skilling will cost around 10% of our budget. So it's probably not possible to screen every patient with diabetes. As we know, that not all MSLT patients progress to the advanced liver disease. Only 1 to 2% of the patient has a significant complication like hepatocellular carcinoma and cirrhosis. So identifying patient at the high risk of progression is crucial for the targeted intervention. In India, only the usual the expenditure is around 13,000 or 14,000 per year. Usually diabetic patient has expenditure, and the cost of the screening is very much. The routine screening as fibroscan, if it is possible, I think the most of the cities in India it is not possible to do the fibroscan, and it costs around 3,000 to 7,000. MRI it costs around 8,000. Is it possible in our country? Probably not. What is the alternative approach? As our previous speaker already said, the risk-based screening is important. Focusing on the high-risk group like obese patient, those with elevated liver enzyme, it may be cost-effective. And the non-invasive tool are more effective than the invasive tool or the fibroscan. FIB4 scanning is the most important. What about we can do after the screening? Probably we cannot do much, because apart from the usual diabetic treatment, lifestyle change, as Dr. Sandeep Tak has already said, is the most important, and it benefits both diabetes and MSLD. There is no need for additional screening when treatment is the same. Weight loss and glucose control improve the liver health also. What is the false positive and unnecessary treatment? Imaging blood test may yield the false positive test. Patient may undergo unnecessary treatment or liver biopsies. So there may be misdiagnosis and causing more harm and prone. And we already know the FIB4 index is a quite specific and sensitive as for the fibroscan and liver biopsy. So it can be a better tool than the complete scanning. Financial burden and priorities we have to take care of in India. Cost effectiveness. Universal scanning may not be cost effective. And public health priorities, we have in India so many other priorities are also, and we don't have a budget. If we are only going to screen the liver, we will be like that. We may be rich or we may take care of liver, but what about the other problems? Probably we are not able to take. And what is the evidence from the Indian studies? In Eastern India reported a prevalence of 55%. Another study highlight a prevalence of 70% in diabetic population. High prevalence rates as a universal screening may not be practical or necessary. There may be ethical consideration of forcing every patient for the screening. So we have to prioritize the more critical screening. Diabetic patient have higher risk of heart disease, kidney disease, and neuropathy. Probably these are the more important complications that should be we should screening. The healthcare focus should be life saving and screening that be focused on these diseases, because as we can see the maximum 66% mortality are because of the cardiac problem. So the more focus on the cardiac problem than the kidney disease. What about the international perspective? The global guidelines recommend the screening in high risk group rather than the universal screening, and it is applicable to India also. So to conclude, Mandatory MSLD screening for all diabetic patients in India is not justified due to high prevalence, variable disease progression, and resource constraint. Recommendation implemented risk-based screening study focusing on the high-risk individual should be done, and the allocate resources to preventive measure like if lifestyle intervention and public health education is more important rather than the screening. These are the references. Thank you.